Hello everyone, welcome back to my channel, and today we are going to start with the sixth video of this series, which is about immunohemolytic anemia. And before you watch this video, I will recommend all of you to watch the previous videos of this series to get a proper overview of this chapter. But before really getting into the chapter, let's start with a small story. See, the bloodstream is a huge city and millions of peaceful RBCs live here. And they have a job, they carry oxygen. And the body's immune system is like the army. It protects them. But one day suddenly confusion starts and the immune soldiers begin thinking that, oh my god, this RBCs look suspicious. And what happens? The antibodies starts attacking the RBCs. This lead to RBC destruction, hemolysis and anemia. Now, there are three main styles of attack. First one is the warm antibody reaction, second one is the cold agglutinin reaction, and the third one is the cold hemolysin reaction. The first one uses IgG at a temperature of 37 degrees Celsius. The second one requires IgM, and as the name says, it requires a cold temperature. The third one requires the same antibody like the first one, which is IgG, but requires a temperature like the second one, which is cold. So this is the overall story about immunohemolytic anemia, and now we will be going into the details. Starting with the definition, immunohemolytic anemia is caused by antibodies that recognize RBC and cause their premature hemolysis. It can be an autoimmune disease which is known as autoimmune hemolytic anemia, or it can be also initiated by drugs. Okay. Now, how do we detect it? We detect it using a test called Coombs test. Imagine there's a classroom full of students. The students are analogous to the RBCs, and there are invisible markers placed on some of the students, and these markers are the antibodies. Okay, so now the teacher brings a special detective chemical. This special detective chemical is the Coombs reagent, and it finds the antibodies attached to the RBCs. It forms clumps and then it agglutinates, and hence we get a positive test result. What is the main purpose of this Coombs test? It detects the antibodies or the complements attached to the RBCs. It can be of two types. Either it can be direct or it can be indirect. In direct Coombs test, the RBCs are already under attack. The antibodies are sitting on their surfaces, and the antibodies are too tiny to cause clumping. So we add the Coombs reagent, and this reagent does what? It joins the antibody coated RBCs together, and it makes the clumping visible. So what it detects? It detects the antibody or the complement that is already attached to the patient RBCs. So what's the procedure? First of all, the patient blood is taken. The RBCs are separated and washed. Why is it washed? It's washed because the serum had free antibodies, and after washing it removes the free antibodies. Now the RBCs are placed in the test tube, and then we add the Coombs reagent. This Coombs reagent is also known as anti-human globulin, which means they are antibodies specific for human immunoglobulin or human antibodies. So when they meet the antibodies attached to the RBCs, they basically act as antibodies to those antibodies. So it will react and lead to agglutination. However, if there are no antibodies attached to the RBCs, there will be no agglutination, no reaction. But if agglutination happens, then the clumping is visible and it gives us a positive test. So that was the direct Coombs test. Now coming to indirect Coombs test, here we detect free antibodies in patient's serum. The antibodies are not yet attached to the RBCs, and they're floating freely in the serum looking for the targets. So now we want to know that does the serum contain anti-RBC antibodies? And to know the answer, we add test RBCs. If the serum antibodies get attached to those test RBCs, then Coombs reagent can make the clumping visible. So we use this process to detect free antibodies in patient serum. That's the entire story. Now what's the procedure? First, the patient blood is collected and the serum is separated. This serum may contain the antibodies. Now the RBCs with known antigens are added. These are called the test RBCs. Now if the patient serum contains the antibodies, they will attach to this RBC surface. But however, no visible clumping occurs yet, because the IgG antibodies are too small to cross-link the RBCs. So the reaction is invisible. Now we wash the RBCs several times to remove all the free antibodies floating around. Only the antibodies attached to the RBCs will remain. Now we add the Coombs reagent, and this reagent will bind to the antibodies which is already attached to the RBCs. Therefore, RBCs with antibodies will show agglutination, and it's a positive test. However, if no clumping occurs, then it's a negative test, and it means that no antibodies are detected in the patient's serum. So now direct Coombs tests are used for autoimmune hemolytic anemia, then hemolytic disease of newborn, then hemolytic transfusion reaction, etc. However, indirect Coombs tests are used for blood transfusion testing, then pregnancy screening, and for detecting anti-RBC antibodies. So let's once recap the differences. In direct Coombs test, we detect the antibodies on RBCs, and in indirect, we detect the free antibodies in the serum. In direct Coombs test, the sample is patient's RBC, and in indirect Coombs test, the sample is patient's serum. Here we have in vivo coating of antibodies, and in indirect reaction, we have in vitro reaction of antibodies. Now let's come to the classification. The first one is warm antibody type, the second one is cold agglutinin type, and the third one is cold hemolysin type. The warm antibody type reaction works best at 37 degrees Celsius. It is mediated by immunoglobulin G antibodies, which sticks to the RBCs, and it is recognized by the spleen's macrophage. Now what it does? It starts biting pieces of the RBC membrane. So the RBC loses its membrane little by little and forms spherocytes, and this is further demolished by extravascular hemolysis. The primary cause is idiopathic, but the secondary causes are associated with SLE, CLL, drugs like penicillin, cephalosporin, which attach to the RBC membrane, and the body forms antibodies against that drug, and so RBC becomes an accidental target. So here we use direct Coombs test to detect the antibodies already attached to the RBCs. Now, the cold agglutinin type reactions works best at low temperature, that is around 0 degrees Celsius to 4 degrees Celsius. Here, this temperature activates IgM antibodies, which lead to the binding of red cells in the vascular beds. This agglutinates the red cells and leads to complement fixation. Why? Because the clumped RBCs activate the complement system. But now when the blood moves back to warmer central circulation, that is around 37 degrees Celsius, the IgM antibody detaches from the RBC. However, the complement system is still attached. So the liver, macrophage, they can recognize the RBC having the complement system, and they destroys the RBC. As IgM becomes active in cold temperature, hence the most common causes are Mycoplasma pneumonia, Epstein-Barr virus, cytomegalovirus, influenza virus, and HIV. The symptoms are pallor, cyanosis, Raynaud's disease, and hemolysis. Coming to the cold hemolysin type, it can be seen in paroxysmal cold hemoglobinuria. Here the antibodies bind RBCs in the cold temperature, but however it causes hemolysis whenever the blood warms again. So this is different from the ordinary cold agglutinins. It is mediated by antibody IgG, and it activates the complement system strongly. So it forms a membrane attack complex, and this MAC punches a hole in the RBC membrane, resulting in intravascular hemolysis. So we can find hemoglobinuria in this case. So under the classification of immunohemolytic anemia, we had learnt about warm antibody type, cold agglutinin type, and the cold hemolysin type. In the warm antibody type reaction works best at 37 degrees Celsius, and it is mediated by IgG antibodies, and it leads to extravascular hemolysis. The cold agglutinin type works best at low temperature around 0 degrees Celsius to 4 degrees Celsius, and it is mediated by IgM antibodies, and at the end it is destroyed by the liver and the macrophages due to the attachment of the complement remains. The third one is cold hemolysin type, which is seen in paroxysmal cold hemoglobinuria. Here antibodies bind the RBCs in the cold temperatures, but destruction happens once it returns back to the warm temperature, and the mediator is IgG, and here intravascular hemolysis happens, which leads to hemoglobinuria. So that was all about immunohemolytic anemia, and now we will be seeing a bit about hemolytic anemia due to red cell trauma, and we will be learning about microangiopathic hemolytic anemia. We know that RBCs travel peacefully through the blood vessels, However, when there are fibrin strands, narrow passages, mechanical stress, etc. inside the vessel, the RBCs get crushed into these obstacles and it gets sliced apart like tomatoes through a wire cutter. This produces schistocytes, which are basically fragmented RBCs. Now, where are these conditions seen? First of all, it is seen in DIC, that is disseminated intravascular coagulation. Then it can be seen in TTP, that is thrombotic thrombocytopenic purpura. Then it can be seen in HUS, that is hemolytic uremic syndrome. It can be seen in malignant hypertension, SLE, etc. These abnormal vessels lead to turbulence, which results in the accumulation of fibrin strands and causes mechanical RBC injury, and this will lead to fragmentation hemolysis. Now, what are the types of RBCs that is seen under the microscope? We can find schistocytes that we talked about. Then there are various other types of cells like triangular cell, horn cell, helmet cell, microspherocyte, Burr cell, etc. You can see them in the pictures. So these are the types of RBC that can be seen in case of red cell trauma. So that completes our hemolytic anemia series. Now I want you all to go and read the same chapter from Robbins and tally your knowledge with it. Fine, so that's the end of the chapter today, and next day we will be starting with macrocytic anemia.